Hello, everyone, and welcome to HeadWise, the videocast and podcast of the National Headache Foundation. I'm Dr. Lindsay Weitzel. I'm the founder of Migraine Nation, and I have a history of chronic and daily migraine that began at the age of 4. I am excited to be here today with a repeat guest, headache medicine specialist, Dr. Fred Cohen. Hello, Dr. Cohen. How are you today?
Hi, thank you for having me back.
Dr. Cohen is an assistant professor at the Icahn School of Medicine at Mount Sinai. He always has just awesome things to tell us, and I'm really excited to have him here today. We have a bit of an unusual topic. Our topic is complex migraine. Some people might be thinking, what on earth is that? I've been wanting to cover this topic for some time now because a number of people are being diagnosed with complex migraine. And believe it or not, it's not even a diagnosis listed in the ICHD-3. This means this is not a classification of headache that has been formally recognized by the International Headache Society. And also the information online, if you are to Google complex migraine, can be a little bit confusing. So I'm hoping that Dr. Cohen can sort of elucidate for us what this is and why many people are being diagnosed with this term. So Dr. Cohen, for people that have not been on and watched before when you have been our guest, can you just tell us really quickly why you love working in headache medicine so much?
Sure. So my short background is when I was an intern in internal medicine, I suffered migraine my whole life, just dealt with it, never knew what it was. In residency, it all got much worse because you're working so many hours in a hospital, and it was there I got referred to a headache medicine specialist. Never knew it was a thing. And I got treated. My migraine got way better. And then that's all I knew what I wanted to do. So that's why I started getting into this. And a lot of people were thinking like, oh, what's headache? What's migraine? Because I just thought my whole life I had headaches. That's how I dealt with it. But I had this severe throbbing pain. I got it once a week. And it's more than just a headache. There's something we could do about it.
Okay. All right. Well, I think it helps for us to know your motivation for working in the field. So I always like to ask you that question. So my first question might seem a little bit obvious for some of the people listening in, but in case people haven't heard our episodes before or just don't know, I don't want to talk about complex migraine without first defining exactly what a regular migraine is. So can you just tell us what a regular migraine, not a complex migraine, a regular migraine is really quick?
Sure. So a migraine is a condition that there's a couple of features to it. That it's a headache, you're having pain that's usually moderate to severe. A lot of people think it has to be unilateral, one-sided. It could be both. A lot of people think it has to be behind your eyes or in front of your head, which is the common presentation, but it could be on the side and in the back of the head. What's important is really the severity. It's moderate to severe, and that it lasts at least 4 hours. That kind of pain is what we classify a migraine. It's not like, oh, I get a headache for like 10 minutes, it's dull. It's usually enough to be interfering with one's life. Most people, the common thing we hear is, oh, I have to go to a dark and quiet room. Because typically it's associated with features such as a light sensitivity, sound sensitivity, sensitive to smells. There can be nausea, there can be vomiting. And again, it has to be all those things. There are people who have none of those associated features. But again, it's just more than just having this pain. Other areas are affected.
Okay. So let's move on then, now that we know what a normal, typical migraine is. Let's move on to talk about what our topic today is, which is complex migraine, which, as I said, is maybe not a true listed diagnosis according to most headache specialists. Yet, as someone who's in the migraine community and watches and listens to what people are saying, many people are coming home, sometimes even after a hospitalization, and have been diagnosed with something called complex migraine. And they're posting in support groups and asking, what is this? I don't really understand it. So let's talk about why this is happening and why people are being categorized as having complex migraine.
So complex migraine is a term I hear a lot. And I'm very happy you're bringing this up because I think it's important to sort of clarify what that really means. Because I see it time and time again, patients get referred to me, they come from another physician or provider. They said, oh, I've been told I have a complex migraine. Because you hit it on the head before, whereas, oh, this headache society doesn't really have this diagnosis because we don't use that term. There are different classifications of migraine. We were bringing about, and you were saying what's typical, not typical. First, I always tell my patients, every migraine, every headache is unique. We're humans with pain. We don't always follow the textbook. And it sort of breaks down migraine to what we call typical aura and what not would be a typical aura. Typical aura is what most people sort of think of in a stereotypical migraine presentation, the aura symptom being like scintillating lights, meaning like sort of zigzags flashing around, maybe a blind spot, tunnel vision, tingliness in the hands or face, maybe difficulty understanding or sort of feeling it hard to speak. And that's what most aura symptoms are. And by the way, I want to add, only about 30% of people with migraine get aura. That means the majority don't have any of these symptoms I'm talking about.
Right.
But those is what most aura symptoms have. But then we get into the not typical per se. And this is what most providers, not headache specialists, most other providers will sort of label as complex. But again, it's sort of this bigger family. And that breaks down to what we call migraine with brainstem aura. That is also hemiplegic migraine, retinal migraine. It's also a migraine with unilateral motor symptoms, MUMS. And that sort of encompasses all what is termed complex migraine.
Mm-hmm. So I find that so interesting that you said that, because I think when I opened up this conversation with you and said that I think we should do an episode on this to elucidate some of this confusion, elucidate this topic for people that were talking to me about what their symptoms were when they had been diagnosed with complex migraine. I was wondering, gosh, how do they know that wasn't hemiplegic migraine, for example, because many of the symptoms they were describing were, I would almost just call it maybe a more severe aura than your average aura. And it was all being stuck in this box of complex migraine.
Mm-hmm.
So what are some of the things, like, just, I would like to just bring up, like, someone just recently, I do know, had some paralysis issues, for example, numbness and some paralysis on one side of the body. So is that something that people are throwing in with complex migraine, and what else could it be?
So that it sounds like it could be either hemiplegic migraine or MUMS. And hemiplegic sort of is when you have, in addition to having sensory numbness, you have a motor weakness. It could be very scary because it can mimic a stroke. And you have MUMS as well. And I always get asked, well, what's the difference between MUMS and hemiplegic migraine? Hemiplegic migraine generally occurs in youth. It's not common for it to present when we're older. Typically, the classical presentation is, well, one, there's a strong genetic component. There are genes we know confirmed to be associated with it. And it typically presents in someone's teens, whereas MUMS could present later. And also, in an individual with MUMS, typically the weakness will last longer, whereas the hemiplegic is just during the aura episode. And one of the key features of MUMS is there's something called giveaway weakness, where someone who has true hemiplegic migraine, if I was to say, oh, grab my hand, or if I was to push against their hand, they wouldn't be able to do it. Whereas in MUMS, giveaway weakness is when at first there's resistance, then it gives out. That's sort of a way we differentiate it. And that matters because it goes with treatment. In these sort of complex migraine, hemiplegic, brainstem, or retinal migraine, we typically don't treat with triptans, whereas in MUMS, triptans are treated with. But what you're describing sounds like it could be hemiplegic or MUMS.
Okay. So one of my next questions was going to be, if someone is diagnosed with complex migraine, is it treated the same as typical migraine? But it almost sounds like it could be a number of different types of migraine and you might not know. So I was wondering if you could comment on that.
Yeah, so really the big treatments that make it different is dihydroergotamine and triptans, which are common rescue medications. And retinal migraine and hemiplegic migraine is typically not prescribed as concern and might provoke or lead to a kind of stroke. Brainstem aura, the current consensus is to avoid it. There is a theoretical concern that it could provoke a stroke or cause some kind of vessel dilemma, some kind of issue with that, because those treatments do cause vasoconstriction. When it comes to preventives, the only one would be beta blockers. You might have heard of people on like propranolol, timolol, nadolol. These are first-line treatments for migraine, but in those cases, hemiplegic, retinal, and brainstem, or they might avoid that class. But other common treatments like topiramate, tricyclic antidepressants like Elavil, you have your CGRP monoclonal antibodies like Amivig, Emgality, Ajovy, the Gepants, Nerded. Those are all fine in those conditions. So it's only a certain class of the medications that are avoided. So it does make it does make a bit of a difference, but it doesn't mean it's only a certain amount of the drugs fully root out of all our other common drugs.
Okay. Do you feel that if this is something that people are having trouble with or are experiencing or have been diagnosed with, that they should see a headache specialist?
Yes. Well, first, I will preface that with, if you're someone who is suffering with headaches that are interfering with their lives, speak to your doctor. There's so many people when they come to see me, they're like, oh, I had no idea this was migraine or other kinds of headaches. I had no idea that there was doctors like you, treatments. So I always say, bring it up with your doctor. And then someone who's suffering from a kind of migraine like these, let me also highlight, we haven't talked much about brainstem aura. Just real quickly, brainstem aura is if you have vertigo, tinnitus, which is ringing in the ear. If you have dysarthria is that you have troubles speak, there's aphasia and dysarthria, which are very easily confused. Aphasia is you have trouble understanding, or in your mind, you're like, oh, I know what I want to say, but I just can't say it. Whereas dysarthria is you're slurring your speech. One is sort of a motor issue. Right. That's not having difficulty understanding and difficulty speaking, from a motor standpoint, is actually typical aura. There's a famous video, I forgot, it was very recent actually, of a reporter in LA where on the air, she just started saying random words. But she doesn't slur her speech. She just says random things and stops talking. Like she becomes unresponsive, just staring at the camera. I remember they sent it to the hospital. They thought she was having a stroke, and it ended up it being just migraine with aura. Whereas dysarthria, what I'm talking about is that you're speaking, but again, this sort of mimics a stroke. You're slurring your speech. But that's sort of what encompasses brainstem aura. But all these are really sort of concerning things. And that's why it is important to go back to your question, to see a headache specialist, because a lot of these we need to assess for other neurological conditions. Right. We have to make sure there's not something else after. One of the primary objectives of an evaluation with someone in office is making sure this is a headache diagnosis and not that there's something else happening that we have to evaluate for.
Okay. Is there any particular reason, any of these types of aura that you want to go deeper into that could be dangerous, or that maybe people should be getting a different treatment for than what they're getting because it's sort of been lumped into this complex migraine diagnosis?
I don't know if I want to throw the term dangerous. Sort of like, it is important to have, instead of just being labeled with complex migraine, know what you have. For instance, we do know women with migraine with aura, all aura, it doesn't matter which kind, all aura have an inherent small increased risk of stroke. And therefore, when I meet a patient that I make that diagnosis, I do discuss I evaluate for other risk factors. Do they smoke tobacco? Are they on estrogen-based birth control? Do they have high blood pressure? Because I don't want to scare those listening, like, I have migraine with aura, I'm going to have a stroke. The risk, it's there, but it's small, but we make sure there's not other risk factors that further increase that risk. So that's why it is important to have and I don't want to say actual diagnosis, but a more concrete diagnosis than complex migraine, so that risk stratification could go into that us as providers could do that. So that's why I think it is to have that kind of at least a visit with a specialist such as myself. Okay.
So some people get symptoms with their complex migraine attacks that might be more likely to be categorized as psychogenic. So can you maybe comment on that?
Sure. So just to give, I guess, context, the term psychogenic is essentially the symptom, because people think when they hear that, oh, it's in my mind. What is the brain? Meaning pain is all in your mind, technically. Pain is not an organic thing. It's your brain thinking that there's a signal there. So psychogenic, essentially, when that term is used, is, let's say I'm having tons of pain in my hand, just give an example, and I get tested, I get nerve testing, all this, it all comes back clean, normal. Oh, well, it's psychogenic, meaning the brain is interpreting that there's a stimulus there, but my hand is not actually in danger. So we go back to sort of with migraine, And that what is migraine? It's sort of this inflammatory cycle going on, that all these various nerve circuits, if you will, are going off you. It's heavily affecting your autonomic system. So that's why other symptoms could happen. I'll give myself as an example. When I was an intern in residency, I was with my attending, and all of a sudden my attending starts shining his pen light in my eye. And he looks at me and goes, your left pupil is blown, it's dilated. I look in the mirror and yep, it is big, like visibly big. And it's never been like that. And that's a scary symptom. I got sent to the emergency room. They did a whole workup. They were like, everything else is fine. I saw my headache doctor, and she was like, there's nothing really accounted for this. They got me an MRI because that has to be worked up, all normal. And it went away. Why did I have that? And it was just ruled to be what it was likely your migraine, that when the migraine cascade, when that attack happened, that something either in the autonomic system or what have you went off and caused that. So that's why I don't per se like it when patients get labeled as, oh, that's like, oh, it's just in your head, it's psychogenic. Like it's likely from what's happening in this migraine cycle. However, it must be worked up. Right. I get a lot of various aura symptoms that come to my office. Like I was saying earlier, while we have what we call typical, not typical, every headache is unique. I've seen pretty interesting things. And for the most part, they're accounted for by aura, but I send them for maybe different kinds of blood work or imaging. We make sure that's the case, that it's from this migraine cascade and not from another process going on. So when you hear that term psychogenic, I don't like to think like, oh, it's just in my head. Well, yeah, your brain is there. So technically it is in your head, but it's just your brain is interpreting one of these inflammatory signals as a symptom and thinking that there's actually a real, if you will, stimulus. And our brain's like computers. It's misinterpreting. You can think of it like that. Right.
I'm glad that you said that, because there's so much stigma that goes along with migraine to begin with. And then if you're given a diagnosis that's different and that you can't really find online, and then to add it all together, sometimes the doctor will be like that one of your symptoms was psychogenic. Going home with all that can be a lot to deal with. And I am seeing it happening a lot surrounding this term complex migraine. So I hope that put people's minds at ease. I hope that this episode put some people's minds at ease. Is there anything else you'd like to add to this topic before we go today?
Yeah, just that I have a lot of patients sort of want to seek an answer, if you will. Am I having these symptoms? Why is this happening? And we have some answers of why migraine's happening. We don't have the full picture. I always joke, and maybe this will be dated in 5-10 years to whoever figures this out. But if you figure out entirely what's happening in a migraine, you win the Nobel Prize in medicine. We know parts of the piece of the puzzle, but we don't have all the parts. Right. And I tell patients like I might not be able to give you a full exact answer, meaning I can tell you what in your brain circuits essentially is leading to you feeling the system, but what sparked it. I don't want you to sort of stress finding that answer, but just there's something that accounts for it. Because that's a question we all have. Why am I in pain? Why is this happening? That, again, migraine is in essence an inflammatory condition. And for treatment, we find ways to reduce that inflammation. And that some patients, it stresses them out a lot. And I understand that. Again, I'm someone who gets migraine myself. But know that we might not always get full exact answers.
Yes, I always like to tell people that medicine is often approached like we already know everything, and in this field, I'm sorry, we just don't. So never just assume that you're going in.
Doctors only know 50% of medicine, and that's so very true.
Right. So never assume that all the answers are there. Just assume that you're getting the best that you can. And we have so many new medicines, etc. So anyways, thank you so much for your time. And I hope everyone enjoyed this episode and learned something. And everyone, please join us again on our next episode of HeadWise. Have a wonderful day. Bye-bye.